Hello, welcome out everybody. This is Dr. Thomas Shipley. Welcome you all out to our webinar tonight. This is the second part of a two-part lecture. For those of you that tuned in last month, we gave a reasonable basis for when, where, and how to choose where to place your micro-osteoperforations, and today we're going to venture into doing some more challenging cases with Propel after a small amount of background information. Just help me get the jitters out of the way. Again, this is my family for those that, same picture as last time, but for those that are tuning in the first time, this is my family of 5 kids. My oldest, my twin girls, are turning 16 next week, and then my youngest boy there in the picture, this guy, he's turning 5 and just starting kindergarten in next week. So a week from tomorrow he starts kindergarten and 5 children in school. So a new adventure for us for sure. A little bit about me. I'm going to make this real quick because for those of you watching this as a series, you don't want to spend too much time on this. I'm originally a Tennessee hillbilly. I got a Bachelor of Science in Business, University of Kentucky for dental school, West Virginia University, Orthodontics under Dr. Peter Nahn. Started private practice in Peoria, Arizona, which is where I'm at now. One doctor, one location, single practice, working 4 days a week. I am ABO certified. I'm a certified teacher of the 6 Elements Orthodontic Philosophy, and that's the orthodontic philosophy discovered by Dr. Larry Andrews, and that's what I teach on Fridays in an orthodontic residency program here in Arizona. Now I'm a certified Orthodontics provider. I'm an Invisalign Elite provider. You'll see several of my Invisalign cases today. I think that clear aligners and Propel MOPs go very, very nicely together. I'm on the clinical advisory board at Propel by way of disclosure, and of course I get an honorarium for doing this webinar tonight, and the webinar is sponsored by Propel. And as I previously mentioned, I do teach at the Arizona School of Dentistry. So to jump right into this, for those few of you that are just completely new to this, first of all, I encourage you, this is some good information today, but not necessarily the place to start. So if this is your first webinar, don't hang up, but you're going to be very much benefited by going back and watching some of my previous webinars. I think this is my 4th or 5th webinar sponsored through Propel, so we've got quite a bit of body of work for you to go back and review, but I'm going to touch a few bases here with you real quick. There's several ways in which we can cause the bone around the roots of the teeth to remodel faster. One of the most effective ways, and the traditional gold standard way to increase the physiology or get the RAP phenomenon, regional acceleratory phenomenon, is to iatrogenically traumatize the bone. We've got years and years of good research behind orthodontics, and that's illustrated in this left picture. What's going on in this left picture is the cortical plate is exposed, a full thickness flap is laid, and then the operator uses a high-speed handpiece and a burr, usually a small round burr, to make cortical incisions in the cortical plate, and then they come back with that round burr or the high-speed handpiece and come back and make dimples into the bone. The whole purpose of this is to create a cellular response in the bone. The iatrogenic traumatization of the bone, it creates an inflammatory process very similar to the cellular cascade of events that occurs with the initiation of tooth movement. So when we iatrogenically traumatize the bone, more cytokines flood into the area that ultimately cause the osteocytes to turn into either osteoclasts or osteoblasts. So in this picture, that's what's going on. This will really get your teeth moving, but it's invasive, it's expensive to pay the oral surgeon or the periodontist to do this, a week or so of discomfort, and possibly some negative sequelae such as papilla blunting or surgical issues associated with that. So I have done this, not the actual orthodontics procedure or the AAO, but I have been involved as in the orthodontist in moving these teeth, and it's absolutely phenomenal, the results that we can get, and I've documented that on the previous webinars. But is there a way that we can get a similar response to be able to offer it to more patients? So let's say the class 1 mild to moderate crowding probably isn't going to go through this procedure just to accelerate it a few months. So is there a better way? Pesio surgery is a little bit less invasive, but still requiring a flap or a tunnel procedure, still paying an outside provider, still some discomfort, but definitely getting some results with this procedure. Now what we're going to focus on tonight is another way and we can do this, and that's through Propel. Propel is using a surgical grade stainless steel screw to make a hole directly through the soft tissue and then make what we call a micro-osteoperforation or a MOP directly into the cortical plate of the bone. So rather than laying a flap and using a handpiece, going directly through the soft tissue and making a hole. So it seems obvious to the mostly uninformed eye that this would be great if you had a lot of movement, but if you only had a little bit of results, this would work good. But if you had a lot of movement, maybe this wouldn't work, but this would. Well, that's not what I'm saying at all. Actually, what I'm finding is I'm getting just as good, if not better, results with the Propel procedure as what I've traditionally gotten with the accelerated osteogenic orthodontics. So how is that possible? Well, the way that this is possible is how the incisions into the cortical plate are made. This is a rotated lateral here, 3 MOPs or micro-osteoperforations. We call them dimples to the patients in the surface layer of the bone in order to get that wrap response, that iatrogenic traumatization of the bone, which starts that cellular cascade of events. Well, in the orthodontics, we're using a high-speed handpiece and a small round burr, and we know that we use a drill rather than a screw when we want to remove material out of the area and not displace material. For instance, a carpenter, if they've got a nice piece of furniture, they're not just going to screw a screw into that furniture because they run the risk of cracking the wood because the wood can be laterally displaced. What they're going to do instead is use a drill. And as they use a drill, they'll make a drill hole, and as they remove the drill out, wood will fall out onto the floor because the drill is removing wood out of the area. And then to protect the furniture from cracking, they'll then drive the screw in because the screw would displace the wood laterally. Well, when we look at the orthodontics in the top left-hand corner here, because we're using the high-speed handpiece, we're actually removing bone out of the area. And because of that, we're affecting very, very little area around where we make the perforation, hence why we have to make so many cortical incisions and the dimples. Whereas in the bottom picture here, because we're using the screw and not the drill, when we make the screw hole or the dimple, we actually get lateral pressure on the bone, which creates micro stresses or micro fractures in the bone, which radiates out to about 5 to 10 millimeters. If we overlap those microfractures, then we can affect a large surface area of the root and affect the entire root with just a few dimples. So by using a screw rather than an actual drill, we actually get a greater spreading effect of those microstresses or microfractures, which in a healthy manner start that wrap phenomenon, that cellular cascade of events that's going to culminate in more osteoclastic and osteoblastic activity. And the histology shows us that those staining shows us that those microstresses radiate out to about 5 to 10 millimeters. So that's the process we're going to be using in order to get these teeth to move faster. And so that's the whole idea. So these are, for those of you that are already doing the procedure, you probably have one of these 3 devices to do the micro-osteoperforations. The generations don't follow exactly like this, but this would, to make it simple, be the first generation, the second generation, and now with the third generation we have the power tip or the power driver, which is a battery-powered handpiece to help us make those micro-osteoperforations. And I found that the power tip or the power driver does a great job in allowing us to deliver this procedure and this service to the patients in a pain-free manner, very effectively and easy on the practitioner. So again, the Accelerator PT is a cordless, handheld power driver, and then we use the stainless steel surgical grade tips into the driver on the patients. They're disposable tips, one patient use per tip. However, we can do many micro-osteoperforations or MOPs on a single patient in that single use. I've done as many as 80 perforations on one patient in the one visit with the disposable tip. All right, so just as review, why do all of this? Well, let's just real quickly show you some before and afters, fairly simple cases, and then the whole purpose of tonight is getting into some more difficult treatment plans. But again, for those of you where the water's feeling a little bit cold, you're not used to it yet, you may want to go back after this is done, talk to your Propel rep, and maybe watch a recording of some of the previous webinars. So let's do some quick before and afters. Now with the Propel procedure, and this is going to be with Invisalign trays, rather than having the patient change the trays every 14 days, I found that I can quite regularly and safely and effectively have the patients change their trays every 3 days. So in this mild class 2, moderate lower crowding, mild upper crowding case, we use 23 trays on the bottom, and without changing the velocity in the clean check, just the normal 23 trays, we had the patient changing the trays every 3 days because of some class 2 correction on the top. In distalization, we had 43 trays on the top, changing them every 3 days. And we were able to finish this case in 4.5 months. Another quick case, we can see just on the bottom here, we have a canine that's difficult to get leverage on that tooth with Invisalign, a rotated lateral, another rotated cuspid. We've got a deep bite and a significant midline shift. Now in this case, I did micro-osteoperforations, mesial and distal of this 3, this 2, and this 3. And then we gave the patient 35 aligners, and at 3 days per aligner we finished in 4.5 months. So you can see that we got very nice decrowding on the lower. Also we're able to correct the deep bite and significantly improve the midline. Now 35 aligners, 2 weeks per aligner, that would have typically in my practice taken me at least 70 weeks plus a refinement or 2. Now with Invisalign and Propel, now I'm changing the aligners every 3 days, and instead of doing at least 1 to 2 refinements per patient, I'm typically only doing refinements now on a handful of patients and some of my most difficult cases, and we'll show some of those tonight where I did actually do some refinements. But this case was able to finish up nicely in 4.5 months. This is a typical Invisalign Propel case that I'll see day in and day out in my practice. Class 1, moderate crowding. This is certainly not a case that you would do Orthodontics for, but a case that works quite nicely with Propel. We're going to do Propel mesial and distal of each root, upper and lower 2 to 2. You can see the final results. We were able to get the lower crowding resolved. This tricky lateral right here, which is hard for the Invisalign material to grab, uprighted quite nicely, and we were able to resolve the upper crowding. That was done with 36 aligners at 3 days per aligner. We finished in under 6 months. A spacing case, diastema filled with composite lower dark triangles. We did IPR on the bottom, removed the upper composite, and then at the visit, or part of it, and then this same day after I took this picture, we removed the remaining composite in the diastema. From the middle picture to the bottom picture, we gave the patient 19 aligners, and we went from this day to this day in only 8 weeks after the Propel procedure. Now I did Propel on the bottom also, but you can see the micro-osteoperforations that we made in between the roots of the teeth, and quite a bit of space closure and dark triangle reduction in just 8 weeks of time. An anterior crossbite with a little diastema, again IPR on the bottom. This was probably another case where we did probably upper 2 to 2 MOPs, and then maybe lower right 2 to lower left 3 MOPs. Some lower IPR, and we gave the patient 27 aligners at 3 days per aligner. In this case, was able to finish in 4 months. Little easier case down on the bottom, little minor crowding. As always with Propel and Invisalign, they line up quite nicely. This was 14 aligners, and we finished this case in 8 weeks. Another tricky lateral down on the lower right, and some upper crowding on top. This is another case where class 1, mild to moderate crowding. We did MOPs, upper and lower 2 to 2. This is our final result. Nice occlusion, got that lower right lateral nice and uprighted. Crowding resolved. This was 29 aligners, and we finished this case in 5 months. For those of you that are new to seeing my finished cases, this is just my version of a fixed retainer. It's a V-loop fixed retainer made out of 020 Australian arch wire. It's a stiff wire, but yet it's bent down so the patient can floss without having to thread the floss. I mistakenly said it's my version of a fixed retainer. It's the version that I use, although I read about it in the JCO and the AJDO if you want to look that up. Again, these are not the type of cases that you would use Orthodontics or something like that for, but these are the type of cases that if we do Invisalign and a little Propel MOP procedure, it can become much quicker for the patient rather than, you know, in this case, 29 trays. What would that be? 58 aligners. Not including a refinement or two, or 58 weeks not including a refinement or two. So at least a year, if not a year and a half, but instead we were able to finish in 5 months. That's the power of Propel, that's the power of micro-osteoperforations, and that's the way we can stay competitive in this environment. When I say competitive, I'm not necessarily talking about other orthodontists, but with the GPs doing 6-month smiles, or our biggest competitor, just the retail consumer market out there with patients seeming to have less disposable income these days. We've got to give them a good reason to want to better themselves and better their oral health, and being able to complete them in a half or a third of the time is a good way to get motivation to help them be more apt to accept treatment. Now in this case we had some upper first bicuspids extracted by a previous orthodontist, and we've got some relapse there, some lower crowding. So in this case I'm going to do MOPs lower 2 to 2, mesial and distal of the upper 6s and 7s, and with this case we did 24 aligners, and we were able to finish the case in a mere 8 weeks. Deep bite case here with some lower crowding. This case was probably had MOPs upper and lower 4 to 4, so a little bit more difficult case. We were able to resolve the lower crowding and resolve the deep bite. This was 21 aligners, and we were able to finish in 3 months. Now the cases I've just showed you with rapid fire are really where the bread and butter profitability is in Propel orthodontics with micro-osteoperforations, because these are the class 1, slight class 2, slight class 3 with a mild to moderate crowding and maybe a little issue there or a little issue here and there, and we can use braces or Invisalign to really get powerful results, and that's where the bread and butter is in this type of treatment. My goal, however, tonight is not necessarily to focus on these type of cases, but to focus on some more complex cases to wrap up this two-part series. Last rapid fire case. Sigmoid-shaped arches, be nice to get some dental expansion. Here, resolve this lower crown and resolve this deep bite. This patient came in asking for Propel as a referral. We were able to get a significant amount of expansion, resolve the sigmoid-shaped arches, resolve the deep bite, resolve the crowding. Again, these are not easy issues to fix with the liners right here. We were able to get it lined up very nicely. This case had 35 aligners. Typically that would have taken me at least 70 weeks plus a refinement or two, but instead we did 3 days per aligner. We were able to finish the case in 4 months. Now, to real quickly summarize a case from last visit, why do we want to do this? Well, this is an Invisalign case that I did not treat with Propel. She was not interested in surgery to correct her gummy smile, but she did want to have lateral incisor implants replaced. We did this all with Invisalign. We can see here that the canine roots are quite upright, and we need to bodily move those roots. And so we were able to do that with Invisalign. We were able to bodily move those roots, make room for the lateral incisor implants. And as you recall from the last webinar, this case took 3 years. Well, I want to real quickly go back to her initial pictures. Look how youthful she looks here without missing those teeth. And then look how she doesn't quite look as youthful with the missing teeth. Now, it took us 3 years to do this, and during that 3 years, what was she doing? Well, in these pontic spaces, she was removing her Invisalign trays every time she had to eat. So socially, that can be quite traumatic for the patient because it affects how they look and affects their self-esteem. And look at the difference that it makes, how she gets her youthful appearance back after we put the crowns on the implants. But first, you can see that we got good root uprighting on the canines, the implants are placed, and now let's look at the final results. Just with those lateral incisor crowns being placed, she gets her youthful appearance back. The case was restored beautifully, but this took 3 years with 2 refinements. And so this is what our patients have to deal with when we take 1.5 years, 2 years, 3 years to finish our orthodontic treatment. So is there a way in which we can give the same great, excellent treatment that we've always given as orthodontic specialists, but do it in a more time-friendly manner that's going to make the standard of living for our patients that much better? I think that we can. I think that we can do it in a healthy, predictable manner that's going to be better for the patient, healthier movement, more stable, more predictable, and also more time-friendly for the patient. So if we can do that, I think it's becoming our obligation even to probably offer some type of accelerated orthodontics as the science keeps rolling in to confirm these results. So let's look at another congenitally missing lateral incisor case. What difference can we make if we do Propel? So this gentleman we're going to treat similarly. He's a little bit more difficult with the rotated canine. We're going to have to do some IPR, but we want to open that space up. Again, you can see we've got to bodily move the roots. We just can't tip them, or else we won't have room for the lateral incisor implants if we just tip the teeth and the roots are convergent. We're not leaving room for the implant. So we talked last visit about how to place these. So real quickly, I'm just going to review this. There's a lot more meat in the previous webinar, so go back and review that if you need to. But where we would like to activate the roots of the teeth is around the center of resistance or center of rotation of the roots of the teeth. What we know is that if we draw a line through all those centers of rotation of the teeth, the mucogingival junction is pretty much on average going to coincide with those centers of resistance of the teeth. So if we drew a line through all the centers of resistance of the roots of the teeth, and we also have the gingival margin, typically if we want to activate that center of resistance of the tooth, we would want to activate around the mucogingival junction. So if I were only going to do one perforation, it would be here. But I actually like to do at least 2 perforations if we can. I think In certain circumstances, 1 is adequate, but what I would like to do is do 2. And if I'm going to do 2, I'm going to spread them out because we know those microfractures or microstresses in the bone radiate out to about 5 to 10 millimeters. So in that case, I'm going to do 1 above and 1 below the mucogingival junction, and I'm going to activate all the teeth that need rotation. Now, in most of those cases in the rapid fire I just showed you, we only did upper and lower 2 to 2 because those are the teeth that were the rate limiting teeth. But sometimes we may end up doing a full mouth, like the very last rapid fire case where we had the sigmoid arches and needed to do some expansion. And then if we have a very long canine root, we might actually add a 3rd one in, especially if those canines are the most difficult movement with a severe rotation. Might be worth it to try and get 3 micro-osteoperforations. But typically 2 micro-osteoperforations is enough, and if one of those is difficult to achieve, 1 is probably be okay also. So we talked about which teeth to perforate. Quick hint, and maybe the most effective hint, is to look at this sheet offered from Invisalign, and you'll always want to do micro-osteoperforations, almost always anyway, around the moderate and advanced teeth, which they color blue and black for you. And then you can look at the IPR, typically the places that you're IPRing. A lot of times that's a red flag for an area where you might want to do micro-osteoperforations. And then last time we spent a lot of time looking at ClinChecks on tips how to use the ClinCheck software to help you figure out how to do the micro-osteoperforations. And for that lateral incisor missing case, this is the final micro-osteoperforations we came up with, and this is going to be quite severe. Now again, this is atypical. Typically it's only going to be a few teeth when we're being proactive with our treatment. Now again, I like to use the Invisalign ClinCheck to kind of teach people how to determine where they need to take MOPs. But one of the take-homes from the last webinar is that we just have to think through use the same principles as we use in the ClinCheck and take those same principles to the braces cases to determine where to put micro-osteoperforations with the braces, because the Propel MOPs are certainly effective in those cases also. So here's our micro-osteoperforations, 1 above the mucogingival junction, 1 below, and the way we outlined, 3 weeks later the tissue completely heals, and 4 months since Propel, we're really starting to open those spaces up. 9 months since Propel, the case is complete. We did 1 refinement in this case. There's more detail about this case in the last webinar. And now you can see from the occlusal view here that we've got plenty of room for our lateral incisor implants. We're able to completely resolve that severe lower crowding in just 9 months, and he's ready for his implants. So how much better is his life than the previous lady who had to be without her front teeth for 3 years, and he's only without them for 9 months? I think we can use Propel as a powerful tool to make our patients' lives much, much better. And you can see that we got nice upright roots with that also. So that's a quick recap, and I did that on purpose to remind us some of the basics of what we're doing so that as we go forward into this new unventured territory with some new difficult cases, it won't seem so foreign. There is the final implants placed, and now we're just waiting for the final restorations to be restored. Well, here's a patient that's got an interesting situation. He's missing his upper right 6, and he had some lower crowding, wanted Invisalign, and he was adamant that he was never, ever, 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 ever going to replace that tooth with an implant. And so we discussed the possibility of closing that space and determined that we would give it a try, but yet he also wanted to do this with Invisalign. So that's a difficult case. Severe lower crowding, missing an upper molar that we need to close some space. Try to do that with Invisalign. That can be challenging. So that's the type of things that we're going to be talking about tonight, and if we can do cases like this, those class 1 mild to moderate crowding cases should be a slam dunk for you. Here you can see the breadth of that upper right molar space and then the severity of the lower crowding and some mild upper crowding. So I'm going to use I don't have much hope at this point when I started this case of using Invisalign to actually close that space, so we compromised with the patient to put a few brackets on the upper right hand side and a TAD in order to move that molar forward. So our plan is to place a TAD and then use segmental mechanics to mesialize the upper right 6 and at the same time use Invisalign to align the anterior teeth. So my plan was to place the TAD between the 3 and the 4 and then go back and do the Propel or the MOPs procedure. Well, you can see here, here's one half of my blue TAD and here's the other half of my blue TAD. Oops, oh no. The TAD broke. Happens occasionally. It's never a good day, but if it's managed properly, doesn't have to be a horrible day. I have a good relationship with an oral surgeon, sent him over to the oral surgeon, and the oral surgeon was able to remove the tip of the TAD. But we can see here the TAD in the CBCT firmly embedded into the bone, perfect TAD placement. We went through the cortical plate all the way intraradically and through the other cortical plate. Now, keep in mind that this is not what we're wanting to do when we're doing Propel. Deeper is not necessarily better. In fact, if we go this deep while we're doing the Propel procedure, and the Propel tip's only about 7 millimeters long, so this is as deep as you can go. But we absolutely don't need to go this deep when we're doing Propel. We only need to break through the thin layer of cortical plate in order to get the wrap response. So it only takes us a couple of millimeters to break through this cortical plate. We don't have to go this deep in order to get a response. And if we go this deep, the patient's probably going to be uncomfortable because as we go that deep, it puts lateral pressure on the roots, compresses the PDL, and they start to feel that. So just 2 millimeters deep through the cortical plate. So send him to the oral surgeon. The oral surgeon made a tiny little incision, used a burr so that they could remove some bone just around here so they could grab it with a hemostat and twist it out. Well, one of the points of this case is this is one primary reason why we can't use a TAD in order to do the Propel procedure. The TADs made out of titanium are actually quite weak, and even though this is atypical to get it to break, if we were to use a TAD over and over again to make 3, 4, 5, 6 micro-osteoperforations using a TAD, the chances of us breaking the TAD increase exponentially with each use. Also, the tip of the TAD is quite sharp and titanium and soft and dulls quite easily, so the second and third perforations won't work. And of course, because it's not attached to a driver firmly, we don't want to drop the TAD down the throat. So using a TAD is not indicated, the use of a TAD is not indicated for doing the Propel procedure. Well, this set us back a little bit because I was going to do the Propel procedure the same day, but since I didn't have a TAD, there's no point in getting started. So I sent him to the oral surgeon, and then he came back in the next visit. The oral surgeon took this one out, placed a new TAD between the 4 and 5 for me, and then I went and did the micro-osteoperforations in this area to mesialize the molar, and then I also did upper and lower anterior 2 to 2 in order to resolve that crowding. This isn't a perfect x-ray showing the MOPs, but you can kind of see what we did here. This is 2 to 2, 2 perforations here, 2 here, 2 here, 2 here, 2 here, 2 here. The ones on the bottom didn't show up so great through here, but we did 2 to 2 on the bottom, and then we did several MOPs in the extraction site. Now you can see our mechanics are a little bit different because I have a bracket slot on the TAD that I was going to use, but when the oral surgeon placed his TAD, he only had a ball on the TAD. So what I was going to do with my TAD was put a wire through the TAD slot and use that to help it from tipping. But when he came back with the new TAD, I didn't have a bracket up here, and so the molar is starting to tip forward. So we're going to have to put some brackets on the 4 and 5 instead in order to help control the tipping of this molar tooth. We'll show that in a minute. So what I've done here is I've got a lingual button on the 3, a TAD over here, and we're moving the molar forward, and we've just trimmed the Invisalign tray to fit over top of that. Now you can see here we're on aligner number 13. In the front, we're changing the aligners every 3 days, just like I normally do with Invisalign and Propel. And at the same time, we're moving these teeth forward. Aligner number 13 is tracking perfectly, as it always does with Invisalign and Propel. So here we are initially. Here we are at 2 weeks post-Propel. You can see that we're already getting rapid movement of the molar forward. The tissue is healed nicely, but we're starting to get that tipping. So what we're going to do is the next visit, diagnose to add some brackets on the 4 and 5. We're then going to trim the tray around those brackets, put in a wire, and then continue to use the power chain from the TAD to the power arm on the translation bracket. This is an Andrews translation bracket. It's specifically a T3 translation bracket. It's got some anti-rotation, anti-angulation in the root to help tip it forward, and then the power arm gets the hook closer to the center of rotation of the tooth, more in line with the TAD, and so we can have the power chain going horizontally across that. Now you can see it where we had the space closed here. As we start to tip the tooth back, you can see we still got some more space to close at the 3-month mark. Here we are 5 months after Propel. We've essentially got the space closed, and we've done, in that 5 months, we've done 55 aligners on the top and the bottom at 3 days per aligner. And you can see here the powerful effect that Propel can have on those anterior crowding, as always perfectly aligned, but now I've put some Kaplan hooks on for settling, and let me show you why. Even though we've got the space closed here, we have a posterior open bite where this is tipped forward. We've got some occlusion issues right here. So now what I'm going to do is use some triangular elastics to help settle this bite. Now at this month, we're 5 months past Propel. I like to re-propel about every 5 to 6 months. Propel recommends re-propelling every 3 to 4 months. So at this point I'm going to re-propel. Now here's a key takeaway from this lecture. When we come back and propel the second time, it's usually not as significant or as troublesome as it is the first time. Remember, the first time we propelled on this case, we had to do mesial and distal of the 7. We had to do upper and lower, anterior region, all those spaces, lots of micro-osteoperforations in this case to get it started. But now these cases are finished and we want to start these anterior teeth are finished, we want to start maintaining these, and so when we come back to do the Propel, now we're only going to propel the top posterior so that these teeth using the elastics can settle down. Are we going to propel the bottom lower? No, because we want these teeth to be our anchorage units. The lower arch is nicely leveled, so we're not going to close this posterior open bite by propelling the top and the bottom. We're going to create a relative differential anchorage unit by not propelling the bottom right, but yes, propelling the upper right. These teeth become anchorage. These teeth will move quite readily with the with the triangular settling elastics. So we re-propelled new MOPs. We do those settling elastics. We trim the tray so that that can settle. At the same time, we're keeping pressure on that molar space so it doesn't upright. You can see here I've put a tipping bend to help aid in the uprighting of that root. 8 months after we started, very nice settling. 10 months since we started, I've under-angulated this picture to show we're not quite there yet, but we're pretty close. The patient feels satisfied with that, and I feel satisfied just with nighttime wear of the Essex that this will settle in on its own. So we go ahead and plan debonding. Excuse me. So here we are with the final results. Nice resolution of the anterior crowding. We're able to close the molar space, and so he doesn't have to have the implant right there. Not a perfect occlusion in the back yet, but I feel quite confident that over several months of just nighttime Essex wear that'll settle in quite nicely, and the case completed in 10 months with Invisalign plus, and by plus I mean a few partial braces on the side. So again, take a patient that doesn't want an implant, take a patient that doesn't want to wear braces, take a patient that's going to go into an office not as fancy and as great as yours, and just do Invisalign and maybe not do as good of a job with you, but because you're reluctant to do Invisalign, you lose the case and the patient loses your excellent expertise. Instead, on the flip side, think about being able to take these difficult cases, now being able to be more competitive because you can use clear aligners, getting great results and doing it in a very time-efficient manner for your patient. Very, very powerful. So this would be, in my opinion, considered to be a more difficult Propel Invisalign case. Again, you can see the results in 10 months, quite a dramatic change in the molar space, improvement in the deep bite, and improvement in the midline shift, all those things that we've already talked about. It's interesting to me that on this side we ended up with from this occlusion to a settled occlusion, and on this side we went from a settled occlusion to an unsettled, but again, I'm quite confident. In fact, history has shown that this settled in quite nicely. All right, let's do a braces case. Now, I'm not a huge extraction man. I'm not afraid to extract those. You know, several cases a year I get extractions, but for me, this is obviously an extraction case from my standpoint. It's also obviously a surgical case from my standpoint. Now, these are 3 initial photos also. I had her give a higher smile right here, and we can see that she's got a gummy smile. We can see that in repose she shows way too much incisor, which is why she's got the procumbent lips. So what I would like to do on her is upper and lower first or second bicuspid extractions, and then do a mandibular advancement and a maxillary impaction. She considers this treatment approach. We put her in braces. She goes through the due diligence process with the surgeon. Despite my encouragement, she chooses not to do the surgery. You can see here the lip strain right here, the dysmorphia in the lips caused by the lip strain, and the procumbent incisors. So upper and lower braces, and we're going to do 4 bicuspid extractions. So here we are. We've got Henry Schein Orthodontics sells Larry Andrews extraction brackets, which are my favorite for extraction cases because they've got overcorrection built into the extraction cases. Translation 1, Translation 2, Translation 3, Translation 4 prescription brackets. So 4 to 12 different prescriptions depending on how you look at it based on the type of extraction case you're using, and it comes with the power arms. And you know, this is what I teach at the school, how to use these translation brackets for space closure. And so what we've done is we put the brackets on. Pretty soon into treatment we're in we get the extractions done, we're in 20 by 20s, and then we've got closed coil springs from the 3s to the 6s, just hook to hook. We don't have to do power chain or springs over top of the wire. We can just connect hook to hook. And then so I've got the spring from 3 to 6, and then a power chain backing it up from 3 to 7 to help retract those canines. Now, when do I propel in this case? Well, this is a maximum, almost a maximum anchorage case for me. I've decided that I want to allow the back teeth to come forward a couple of millimeters, but I want these teeth to come back about 3 millimeters. So initially I'm doing reciprocal space closure because I'm okay to allow the posterior anchorage to slip a millimeter or 2. So I just elect not to use TADs in this case because I'm going to let the anchorage slip very minimally, a millimeter or 2, and plus, because I'm going to use Propel, I can set up a relative differential anchorage case. If I propel the canines and not the posterior teeth, these teeth then become anchorage units because they're going to move at the same excruciatingly slow pace, and the canines, because I propel those, are now going to move at a very rapid case. So no need for TADs because I set up that anchorage unit. Now, do I do Propel right away? No, not on this case. On extraction cases, I like to wait 3 or 4 months after the extraction to do Propel. Why? Because the extraction sites are little mini Orthodontic sites, and just from the process of taking out the teeth, we're going to get an inflammatory response, flood in those cytokines, the wrap procedure, without doing the procedure, without having to do the MOPs. So we don't have to do the MOPs right away. We can wait 3 or 4 months before we do the MOPs. The other thing about this is when we take out the teeth, especially if the dentist or surgeon has been a little bit careless in removing the teeth, we can have either a fractured cortical plate here, or we can have a very thin cortical plate. And if we're trying to use a screw to make a hole in that very, very thin cortical plate with no support underneath, sometimes it's possible to even get a little fracture in that cortical plate. So first of all, we don't need the Propel right after the extractions. Second of all, we want a little bit of bone to fill in before we do those micro-osteoperforations. So we're going to pass on the Propel at this point. Now, 4 months after extractions, you can see we've got good retraction of the canines because of the wrap effect of where we took out the bicuspids, but now we're starting to lose that wrap effect. The bone is starting to fill back in. So now at this point, it's time for Propel. The bone is more solid, so we can Propel without fracturing that layer of cortical plate. The bone has started to fill in, so we could use a kick in the pants with the micro-osteoperforations. So now what I'm going to do is do 2 to 3 micro-perforations, mesial and distal of the canines. Remember, at this point, I don't want this posterior anchorage to slip, so I'm not going to Propel back here, just around the canine. These become anchorage units, no TAD needed, and these will start to distalize faster because of the Propel. Here we are doing the Propel with the power tip, because it's canines. I've elected to do 3 micro-osteoperforations, 1, 2, 3, rather than 2, 1, 2, 3, mesial and distal of the canines to help those retract using the same mechanics. Now again, not back here, so now we're getting differential anchorage here, so those canines are going to come back differentially rather than the posterior teeth come forward. Not perfect like a TAD, but don't have to worry about the TAD mechanics in this case because I'm okay for 1 millimeter or 2 of slippage. All right, 4 months later, the canines are now retracted, and now the posterior anchorage has been retained. No TADs were needed. Now we need to reactivate the MOPs on the upper and lower. Where do I want to place them now? Well, I don't need to retract the canines anymore. What I want to do now is retract upper and 2 to 2, upper and lower 2 to 2. So what I'm going to do is now place the MOPs mesial and distal, upper laterals, upper centrals, lower laterals, lower centrals. So 2 MOPs here, 2 MOPs here, 2 MOPs here, 2 here, 2 here, 2 here, 2 here, 2 here. You get the picture. And then retraction of the anterior segments begins to close those spaces. So MOPs this day, and then we can put a hook, crimp a hook, or put posted arch wire distals to the 2 to retract those teeth. And I believe in this case we've elected just a power chain over top of it to close those spaces, and you can see 11 months after the extractions all the spaces are closed, and we're going to use settling elastics for 1 more month, and then 1 month later we remove the brackets, and we've got a very nice finish. Now she elected not to have the surgery, so not a perfect case, but wow, what an improvement on her facial profile. She's still straining her lip a little bit. I think she doesn't have to, probably. I think she's probably just used to that, but much, much better profile. I'll show the before pictures in a minute. But 1 year, 4 bicuspid extraction case, 2 MOP procedures. We were able to keep our posterior anchorage, maximum anchorage, with no use of TADs, using relative differential anchorage by propelling the teeth we want to move, not propelling the teeth we don't want to move, and getting a nice result this way. Now, would this be a case that I would want to use a vibration device on? Well, because I want to create that relative differential anchorage, I didn't want to speed up the movement of these posterior teeth. So this becomes a very, very powerful use of the micro-osteoperforations rather than a full mouth vibration device. So not only is the MOPs the gold standard, but in this case I think the MOPs are more indicated because we want to control which way the teeth move. If we just want all the teeth to move equally, then a vibration device might be warranted. Let's look at the before and after profile pictures. You can see quite an improvement in the profile here. I showed you the high smile. She wasn't smiling all the way, so if anything, the gummy smile improved a little bit, but look at the inclination of this. Now if she ever wants to go back and do the surgery, she can do an anterior maxillary impaction and a counterclockwise rotation of the mandible and get a very, very nice result. Because she needs that anterior impaction, and as she does that anterior impaction, she'll get some proclination of those upper incisors. So I'm hopeful that one day that she might choose to do the surgery if she shows desires, but more likely not, because she's just ecstatic with the final result. Before Propel, I typically would have diagnosed this case at 2 to 2.5 years. Probably been able to finish it in 2, but I wanted to give myself some leeway usually. But now with Propel, we were able to finish that case in just 1 year. All right, unilateral class 2. Look at these roots. She is a young adult, and she has some very long roots. The roots don't end up here, they end up right here. Way up here at the top of the slide is where the end of those spindly roots are. Class 1 canine on the right, class 2 on the left. You can see the upper rotations here. Rotations of the lower canines, which are going to be proved tricky to correct with Invisalign, which is what she wants to do. She was referred to my office by an Invisalign provider because they didn't want to do Invisalign on her. So how about you figure out MOPs, do the Invisalign cases so they come to you instead. Okay, so you can see here on the x-ray, class 2 canine left, class 1 on the right. Mild to moderate upper and lower crowding. Again, you can see that full step class 2 canine, long canine with extra long roots, probably the longest that I've seen in my practice. So I choose to treat this case with a unilateral carrier class 2 motion. Okay, so here's some more pictures. So here is the class 2 motion in place. Class 2 motion is offered by Henry Schein Orthodontics. Now this is my protocol for adults with class 2 motion. What I'm going to do is day 1 I'm going to deliver the class 2 motion, and then I'm going to place 2 micro-osteoperforations distal to each tooth in the maxillary arch. We're going to use micro-osteoperforations rather than vibration in this case because we don't want the lower anchorage to slip. If we use vibration, we're going to speed up not only the upper movement but also the lower movement. We don't want the lower teeth to procline, so we can really target the area with a powerful MOP procedure. So here's us placing the micro-osteoperforations with the Gen 2 device. There's 1 micro-osteoperforations, 2, 2, 2, 2, and 2. So here we can see where I did the procedure. 2 MOPs here, 2 MOPs here, 2 MOPs here. Ooh, I got a little bit low. Try and stay away from that intercrestal bone. Probably should have placed the MOP here and here rather than here and here. And in this one, that first MOP, I missed completely. So again, when you get posterior, resist the urge to get, you probably want to get a little bit higher because of where the bone actually is, and then 2 back here that you can't see. So here we are 4 months later in that adult. Now 3 to 4 months with carrier motion in a teenager, no big deal. In an adult, full step class 2 with extra long roots, that's going to be tough to get in 3 or 4 months. Here we can see the excellent results that we got in just 4 months. You can see that the tissue has healed nicely. But look what's happened in the front. Before we started, the upper midline was over to the right, and now it's corrected by itself over to the left. So just with a unilateral Class 2 motion device, nothing else going on besides a lower Essex, we're able to get some spacing in between the front teeth, a nice correction to a Class 1 canine, rotation of the molar. Now this becomes a slam dunk Invisalign case. So now what we're going to do is order Invisalign refinement, and on the refinement, now I'm going to, the second time, not going to do the MOPs back here anymore, that's corrected. Now I'm going to do the MOPs mesial and distal of the 2s to help that space close, and mesial and distal of the lower 3s to get those to rotate. So we order the refinement trays, deliver the refinement trays, do the MOPs here, upper 2 to 2, do the MOPs lower 3 to 3, and then we are able to finish the case about 6 months later, changing the aligners every 3 days. So what have we done here? We've taken a case that typically would have been very difficult to correct with aligners alone. Now if you've used a typical Invisalign protocol of just aligners and elastics in the aligners, sometimes it can take you 36 aligner trays coinciding with elastics to determine, hey, the patient wasn't even wearing the rubber bands. But now by using the Carrier Class 2 motion device, that's the only thing we're doing. It's very easy to check compliance. We eliminate the number of trays that we have to monitor by making this a very easy Invisalign case before we even start. In the adult, we allow the MOPs to give us even more of an advantage. A very nice case finished very, very quickly. You can see that we were able to resolve the lower canine carotid as well. The MOPs healed over quite nicely at the end of treatment. And look, if any of you worried about root resorption, we were bodily able to move that canine into a Class 1 position. Bodily movement with this long root. The root apex comes all the way up to here. The root apex comes all the way up to here. Still as spindly to ever. Look at these, still as spindly as ever. So those of you worried about root resorption with the MOPs, less likely to get the root resorption with the MOPs. Here's one of many cases that show those roots moving quite nicely without getting root resorption. Well, how do we know that, nice final results. So how do we know that the MOPs helped us with this Class 2 motion? Class 2 motion is a powerful device, Carrier motion from Henry Schein Orthodontics. But look at this unilateral. In this case, I decided to place the Class 2 motion on both sides. So she's going to wear a Class 2 motion on this side, Class 2 motion on this side. But on this side, I don't need much movement, hardly any at all. On this side, I need a lot. So what I choose to do is to place right and left Class 2 motion. And in this case, I'm going to do the micro-osteoperforation, same as before, distal on this unilateral side, 2, 2, 2, and 2. Now, if it was bilateral, I could do 2, 2, 2, and 2 on both sides. I don't want the lower to come any forward, so I'm not going to propel on the bottom, just on the top. Not going to use a vibration device because I don't want the bottom to move. I want that to be an anchorage device. Now, once I get the Class 2 corrected with the MOPs, then I might transition into a V-Pro 5 from Propel vibration device to help seat the aligners to be more efficient. But right now, I want to be very specific in where I'm placing the MOPs so that I can really create anchorage units. So here we are getting started. Here we are 6 weeks post the unilateral Propel. We're halfway through to our correction. Probably another 6 weeks. When she comes back, we'll have this taken care of. But look at the difference from beginning to end. Here's the, on the left side, we can see the rotation. On this side, this is the control side. I haven't done Propel with the Class 2 motion. Very little movement in this area. Canine still rotated. On the right side, we've got a displaced lateral with no space, but on this side, we did the Propel. Look at the space that we've created. Mesial to the central, mesial to the lateral, mesial to the canine. look at the derotation we're getting of the upper molar, and look at the correction we're getting here. So you can see here the difference that we got on the Propel side versus the non-Propel side. This coincides quite nicely with the 2013 AJA article on Propel. So again, very, very powerful to help us produce that anchorage. This was just yesterday that I showed this, but I thought that it was interesting to show the difference between the Propel side versus the non-Propel side. So again, a little bit more advanced use of Propel, using it with our auxiliaries to help exemplify the results that we get from the auxiliaries. Last case, I might try and squeeze two. We'll see how we do. An expansion case. Look at this interesting case. Upper and lower moderate crowding. This would typically be upper and lower maybe 3 or 2 to 2 down here. But look at this. These teeth right here, these four, the upper right 4 and 5 are displaced lingually, and she's had some composite veneers placed to make this look like the teeth aren't buried in. Well, she wants to resolve the crowding, and she wants to get this fixed. So what I do is I start this as an Invisalign case, and we're going to do the MOPs. We typically would do upper 2 to 2. We got some little rotations of the canines, so upper and lower 3 to 3, but we're going to expand this 4 and 5 out buccally. So can we get buccal expansion with aligners? Well, this is a good case to show that potentially we can. So I'm not going to remove the veneers at first because she's not going to like the way it looks. I'm going to move it out halfway, then remove the veneers, and then move it the rest of the way. So I make my first set of aligners with the veneers in place, and then on the bottom we're going to do lower 3 to 3 plus this lower left 4. I decided it's low rotated, so we might as well do the 4 also. She's going to change her aligners every 3 days. So this is one visit later. She's done 13 aligners, or 39 days, and you can see the amount of expansion that we've got here. Look how far out buccally the 4 and 5 are tipped. At least halfway out, if not more. So on this day, that's where I plan with my Invisalign tray, so I'm going to go ahead and remove these composite veneers and do a refinement. So here we are after the composite veneers are removed, and now I'm going to do a refinement scan. I'm going to expedite the refinement scan because we don't want to lose the effects of the MOPs, so that we can get the aligners back in a week or 2 and then start moving right away. So remove the attachments, do a refinement scan, remove the composite veneers. In our refinement, we've got 14 aligners with both the initial trays and the refinement, 30 total aligners. So 42 days later, in 5 visits with 1 refinement, we're able to complete the case. You can see the awesome expansion we got of the upper right 4 and 5. When she smiles, she's got a very full smile up here on the upper right. We're able to resolve those rotations, the upper and lower crowding, a nice occlusion in the back, and now she's ready to be done. She wanted to be done as quickly as possible, so I'm just going to let these settle in, and now she's got her expansion in a much healthier manner. So can we expand teeth buccally with Propel? Can we get improvement? Absolutely. Very nice expansion of these 2 teeth, and 2 webinars ago I showed where we corrected a bilateral crossbite with Propel doing upper dental expansion also. $5,200. 5 treatment visits, that's not including consults and retainers obviously, but $1,040 of back office chair time, those expensive treatment visits. So very powerful tool. Ooh, I'm a little over. I'm nervous whether I should do this last one or not. It's a great case. Let's give it a try. I'll go in more detail another time. But look at this case. Easy, right? Upper and lower crowding. This could be one of those rapid fires. But uh-oh, look at this. She's missing a second molar here. This is a wisdom tooth. Missing first molars here. This is the second and third molars. So let's look how that looks on the x-rays. Wow. Look at these second and third molars that need to be uprighted. Second and third molars need to be uprighted. Guess what? As typical in this area of town. She wants Invisalign, not braces. So can we do this with Invisalign and some partial braces mechanics? So we put my Henry Schein translation brackets on, the Andrews brackets with the anti-angulation built in to help upright those roots. So partial mechanics to help upright the tooth. Roots, we're going to overlay the over the aligners here to help the aligners seat better. This might be a good V-Pro 5 case, but with the root uprighting, I still feel more comfortable with the micro-osteoperforations. As we upright, we get some side effects, some bite opening with some hard occlusal contacts. And here we are, I think this is mid-treatment. Here we are 6 months later, able to close this space, nice uprighting of the 7 1/8 into that area. Now it's time to remove those posterior brackets, do an Invisalign scan. I did not re-propel on this case, so this is, now we're going full upper and lower Invisalign refinement. Here we are when we're done, a very nice occlusion, able to resolve the anterior crowding. We're able to get the upper roots uprighted with no implants needed to replace the upper 6s. You can see the beginning and end results, and she's very, very happy with her final results. So thank you very much. I wish I had more time to go into that last case. Different day, different venue, I suppose. In summary, Propel is a very, very powerful tool that we can use in order to give the same great, excellent orthodontic care we've always given as orthodontic specialists, if not better. And I think it's our responsibility to the patients to do this, since we can do it in a more predictable, healthy manner, be able to tackle more complex cases, and be able to do it in a very reasonable time frame. So thank you very much. I'm now going to go right into questions. So I've got to find my question pane somewhere and see how many have stacked up. I haven't even looked at them yet. All right, looks like we've got at least 1 or 2 questions. So here we are. First question by Marina. When using a carrier distalizer, they prefer to call it, Luis prefers to call it carrier motion class 2 because we get more than distalization with the class 2 motion. We get repositioning of the condyle, we get rotation of the upper molars, bodily movement of the upper canines, and distal tipping also of the upper canine, also of the upper molars, distalization, repositioning of the lower anterior. So class 2 motion, do you recommend using Invisalign, or can a simple Essex for the mandibular arch suffice until are you ready for full aligner treatment? That's a great question, and the answer is it's totally up to you. Typically, I prefer to do the Essex because we don't have to wait on the ClinCheck and we can get started right away. So typically what I'll do is just do a lower Essex. We can deliver that the same day. Even if we want, take the lower impression first, or use the study model cast, make the lower Essex. While that's pouring up and being fabricated by one assistant, the other assistant can be bonding the class 2 motion devices on, and so the Essex works out very nicely. However, you can use this to be creative for whatever suits the need. Sometimes patients want to get started right away. Sometimes they don't. They want to put it off. So maybe a patient that's got some baby teeth that the parents feel like, oh, I've got to wait till the baby teeth are loose or gone before we start Invisalign. Well, that would be a good case to use an Essex. Or maybe it's at the end of the quarter and you want to, for Invisalign, and you want to increase your rebate or get one more case in because you need it to reach the elite level or something like that. For those, you can go ahead and jump directly into the Invisalign. So schedule the carrier motion appliance in like 3 weeks, order the lower Invisalign trays. So it's totally up to you. My preference is to start with the Essex for one more reason also, because when I'm wearing the elastics, I like the treatment to only be about the elastics, because it's easier that way to hold the patient accountable for their compliance. If we're only doing one thing, which the elastics, they can come back 4 weeks later and I can say, you're not wearing your elastics as the teeth aren't moving. Because with the motion device, you will know if they're wearing the elastics because the teeth will move. Next question by Ravi. How are you accomplishing anesthesia for lower 2 to 2? Previous webinar is going to go at least 20 minutes onto that topic. To get the best anesthesia, I advocate a very precise, rigid protocol for doing that, which I can't summarize in the question phase. But to summarize, we're going to choose either to use local infiltration with a needle, depending on your comfort level with the needle, or if you don't like using needles, you can absolutely get this accomplished with a high-grade topical anesthesia. My preference is BTT. It's a little bit stronger than the TAC5. We place the BTT on for 3 minutes with the topical in order to get that lower anesthesia 2 to 2. But it's a much deeper question than that because I have a very precise protocol. So both the first and second webinars that I did, I believe, shows that, definitely the second webinar. One more question and then I'm going to finish. So if anyone else has a question, ask it right away because this is going to be my last one unless someone asks soon. Not sure if this question has been asked before, but how do you address financing the case fee with these short treatment times? Thank you. Great question. Also been addressed quite extensively in previous webinars. Unfortunately, I'm not quite sure, so that would be a good email to send to the rep and say which Shipley webinar would best address that. But to make a long story short is we do automatic withdrawals for our patients. We've never had our payment plans coincide with treatment time. So if we're going to finish a case in 12 to 18 months, but the patient can only afford $120 a month, and that turns out to be 3 years of payments, we don't blink at saying, okay, treatment will be a year, we're going to do 3 years of payments. And with automatic withdrawals and some other tricks, the patients pay quite readily. In orthodontics, 3 to 4% of the patients typically default. When they default, hardly anyone defaults on $5,000 because you've collected $2,000 of insurance, a down payment, and then several payments before they finally default. So when they default, they only default on $500 or $600. My assumption, and it's an educator's assumption, is by doing Propel, I'm saving probably about $1,500 in chair time per patient. $1,500 in chair time. So, and also the dental insurance reimburses through the dental insurance for the alveoloplasty without extractions, so we may get another $600 from the dental insurance. So let's say we're making an additional $1,500 to $2,000 in efficiency and direct payments from insurance. Even if every single Propel patient defaulted at $500 or $600, we would still be better off. So if I knew that every Propel patient was going to default $500 or $600, I would still do it because I would still be quite a bit better off. But the good news is that out of hundreds of Propel Invisalign cases, I've never had a single Propel patient default on the payments. I think it's because they love us so much, and it's atypical for that to happen. So I'm always shocked myself when every 3 months I print out the report, and there's still not been a single Propel case that has popped up that has defaulted on payments. So the good news is the patients who love you will pay you first. Propel patients love you more than everyone, so payment's not a problem. Just continue collecting your automatic withdrawals. If you don't trust me, which you should, because it's good business to trust me in that regard in so many areas other than just Propel when it comes to extending your payments past treatment time, some other options would be to offer to patients, hey, we can do Propel, But if you decide to pay in full, we're not going to charge you to do the procedure. So let's say you charge $200, $300, $400, $500 to do the procedure. You can waive that fee if they pay the remainder of their balance in full. Another option, if they want to do the Propel and aren't able to pay in full, you could also at that point try and transition them to care credit or outside financing. Those are other options, but what I strongly urge you is to not do any of that and just continue with the regular payment plan, and they will pay you and you'll be better off. So that was the last question that I got. I don't see any other follow-up questions. So 15 minutes over due to me throwing in one more case and about 10 minutes of questions. So I don't see any more questions popping up, so we will drop it there. So thank you very much for being here tonight. I hope you've got a lot out of this series, and I wish you success with your Propel treatment. Thank you very much for coming.